colleagues from all around the country, and also our guests here tonight with us. It's my pleasure to open this dinner symposium hosted by SMT. It's called the G Club Taipei. We are very happy to have this opportunity to have Professor Gianluca Campo from Italy, and also Mr. Enio Suri from India as our foreign guest. So I think I will let Enio to start and give us some kick-off talk.
Yeah, thank you. Good evening, everyone. Good evening, everyone. Thank you, Professor Gao and Dr. Liu and Dr. Campo. Thank you for the nice evening, and like to welcome everyone in the room as well as all the physicians online. So it's my great privilege to be here and share a little bit more about SMT. Maybe a quick background. So I've been in the medical device and the intervention cardiology field for over 20 years. So I joined Guidant in 2002 and moved to Abbott. Spent a lot of time in Singapore working on Absorb, and then in the US working on imaging and physiology. And then last year moved back to India with my family and joined SMT to take care of Asia-Pac region, and very, very happy to be here. Taiwan is a very unique and close to my heart country, because during the Absorb days, Taiwan was one of the front-leading countries around the world to have the most successful clinical outcomes with that interesting technology. And I'm really excited with the skills and the clinical expertise of physicians that SMT has the opportunity to be here in Taiwan. So let me just quickly share a little bit of background about SMT. So I do want to read our overall vision, which is really pledged to save millions. And we want to call out that we are here to serve more and more patients by making healthcare affordable, not cheap, but affordable, but at the same time provide high quality medical devices that can help patients lead better lives and have better clinical outcomes. But very interestingly, SMT was started by a family in the western part of India, which still deals with diamond cutting machinery. So they were the pioneers of diamond cutting, and as you know, diamond cutting requires precision engineering, and that is exactly what stents require. And about 30 years ago, they wanted to serve poor patients in the country, and realized that it's the same technology of precision engineering, laser cutting, that will be used to make stents. And that sort of gave the birth to their medical device division for SMT. Over the next few years, many developments took place. So we were able to, we were able to bring to market our first bare metal stent back in 2001. And we were the pioneers in bringing a biodegradable polymer drug-eluting stent in 2005. So this was the first time globally that a biodegradable polymer drug-eluting stent was received CE mark. Over the next few years, many iterations were made on the stent technology,
and I will share that in a little bit more detail in the next slide. And it's around 2018, 2019 that Supraflex Cruise, which is currently our flagship drug-eluting stent, was CE marked and introduced to the world. Since then, SMT acquired a company in Thailand. So this was Vascular Concepts, which allowed us to access the TAVI market. So our TAVI device called Hydra, which is a self-expanding device, as well as occluder devices, ASTs, VSTs, PDAs, and PFOs. And locally, we've been also able to have a lot of partnerships. So for example, we have a strategic partnership for Penumbra in India. We are the exclusive suppliers of Penumbra in Indian market. And we have also partnership with Insight Lifetech for IVUS in the European market. So not only have we been spending a lot of money in organic development, we've also invested a fair bit in acquisition, and we're also quite agile to form local partnerships wherever it makes strategic sense. So now SMT has been present in over 80 countries. We command leadership position in drug-eluting stents in India. We are amongst the top 5 players in many European markets, Germany, Italy, Spain, Poland. And we've been growing our global presence over the last 4 or 5 years. We're a growth company, so our revenues have been growing pretty strongly since COVID. And we've been able to build a strong organization. So most of our management team has a lot of experience working in the medical device industry. We've built 4 manufacturing plants in India, in Thailand, in Ireland, a couple of R&D facilities. And like I mentioned, we've invested heavily in organic development and therefore built up our patent base over these years. So we're still a sort of mid-size, but growing extremely fast and expanding rapidly around the world. In terms of our key portfolio, just like to highlight that we have a strong product line in cardiovascular with Supraflex Cruise, which is of course available in Taiwan. We just launched Supraflex Cruise Nevo in Europe, which is a more deliverable product than Cruise. In fact, it's the same stent platform, but with a much better delivery system. In terms of structured heart, as I mentioned, we have a TAVI device and we have occluder devices. We also have presence in the endovascular space, not so much in the international market, but we have a drug-coated balloon in the name Peripherix, which is a paclitaxel-coated DCB for the periphery. So we've been able to sort of build a more diversified portfolio, but still quite focused in the vascular space, unlike some of the other bigger players. As I mentioned, since our first drug-eluting stent came to the market, we've been able to improve the deliverability, the trackability of our stents through numerous iterations. And you can see, while it's a little bit of an eye chart on the lower left, but in terms of deliverability, we have some published data from an independent source. This is a center in Germany where they evaluated Supraflex Cruise against some of the contemporary drug-eluting stents and found that the deliverability is much better, Cruise requiring the least amount of push force as compared to other products in the market. We've also invested significantly in generating evidence, and I know Professor Campo will speak more about this. But just to highlight, our journey in terms of clinical evidence really began with the TALENT trial. So this was our first randomized clinical trial, was with the earlier generation Supraflex stent, head-to-head comparison to Xience. This was published in the Lancet. 1-year outcomes were non-inferior to Xience, in fact, numerically better in terms of clinically driven TLF. Now we have published results out to 3 years. So this was, I think, published in 2019. And since then, we've been able to expand our presence internationally. Last year, of course, we had Professor Campo publish the FIRE trial data, which he'll speak about in greater detail. But a New England publication, a landmark trial in many, many, many aspects. And we were very fortunate to have been associated with this trial using Supraflex screws in both the arms. Last TCT, we also had results of another interesting randomized clinical trial study called the Compare 6080, which compared Supraflex screws with Ultimaster Tansai in HBR population. So again, a high-risk population, and we showed significantly better outcomes, both in terms of TLR and ST as compared to Ultimaster Tansai. We have just completed enrollment in 2 large randomized clinical trials. So multi-vessel talent, which is another complex patient subset, a multi-vessel disease. This is Cruz versus Synergy. And again, Professor Campo will speak more about this. So we just completed enrollment on that. And then a diabetic trial, multi-vessel diabetic study with 1,800 patients randomizing Cruz against Xience. And both of these studies have just completed enrollment, and we're hoping that the results could be presented either towards end of next year TCT or early in 26. Another very interesting study out of Switzerland has been initiated. So this is Matrix 2. Again, a very complex patient population, atrial fibrillation patients requiring PCI, and again, a very, very interesting, would be a landmark study. 3,000 patients, so it'll be a while before this gets completed. Professor Stefan Wendiker is the PI for this study. So we've been spending a lot of our efforts in building the clinical evidence in close to 7,000 patients in various RCTs as we look ahead. Similarly, we recognize that there is also merit in investing in real-world registries, and we've been very committed to a lot of very interesting registries. So from all-comer registries to HBR registries to octogenarian population that we've studied in Cruz Senior trial in Europe, 2,500 patients. So again, large registries in the UK, which just got published in BMJ online. SFlex Netherlands, which is 5,000 patients, I think is close to enrollment completion. And then Cruz HBR was already published, and that sort of set the pathway for Compare 6080 in HBR patients. So again, I feel extremely happy to see that the organization has invested a lot of its efforts in building evidence, and you will see in the upcoming slides that the evidence really stacks up very, very strongly against all of the contemporary drug-eluting stents in the market today. Just a quick note on our TAVI device. So again, our Hydra, which is a self-expanding supraannular bovine pericardium device. It's now approved in over 50 countries, and we've sort of presented our 3-year results for the CE study in last year London Valves, and you can see that both in terms of the mean aortic gradient as well as the effective orifice area, the results panned out very, very well post-procedurally out to 3 years. So I think in the coming year, we'll be presenting the 5-year results, and we're quite encouraged that we didn't see any moderate or severe PVL out to 3 years. The the functional scores improved dramatically. And again, very promising. Again, very promising device that we're really excited about. We're now adding the external skirt, so bringing in another iteration of this device, and soon we'll be starting a randomized clinical trial study with some of the contemporary TAVI device in the market. So while this is not an extensive list, but we do have a comprehensive pipeline in our bag. So we're already working on new generation of stents, balloons, high pressure balloons, even DCB. On the coronary side, we're improving our delivery capabilities on structural heart, and we're also expanding our portfolio in the peripheral intervention space. Not to say that we're always on the lookout for interesting new technologies that we can acquire or even partner with, and that's the beauty of working in a much more focused and nimble organization compared to some of the large multinationals. Needless to say, we've been very privileged to have worked with some of the best names around the globe. Again, this is not an extensive list, but I'm sure some of these physicians are your peers and colleagues, and it's been under their guidance all along that we've been able to build an extensive clinical evidence base. We also worked closely with the Corib Research Centre and the University of Ireland in Galway with Professor Sarais to build this Syntax Score app. So that's freely available on the Android as well as the iOS application, and this just allows you to get Syntax Score when the patient is on the table or off the table by entering the data, and helps just aids decision making utilizing the current evidence that's published out there. So in the end, I just want to leave you all with a few takeaways as far as SMT is concerned. It's a growing organization. We still feel we have a huge opportunity to continue to grow our business. And the growth in business also means that we will continue to invest back in building evidence, back in partnering with all of you, back in improving technology. And like I mentioned, we're focused on the vascular space, so that allows us to again continuously improve and build on our existing foundation. We are quite a nimble and a flexible organization, just 2,500 people, a lot of them in manufacturing. So you can imagine that you don't have to, if you have a research idea, it's not that we have to go through 20 different committees to get an answer. If that sounds interesting, I think we'll be able to come back fairly quickly and partner with all of you. I already mentioned that affordability is one of our bedrocks, so we're definitely a for-profit organization, but at the same time, we do recognize that the disease burden is immense, and not everyone can afford devices for their better health, and therefore we're always very flexible in working closely with you to bring high-quality products, but at affordable prices, so you can treat more patients, improve more lives, and create more happiness around the world. So with that, I'd like to thank you all for your kind attention and the opportunity for me to share a little bit about SMT.
Anil, for your road mapping of your company's product portfolio and also research pipelines. I think that's a wonderful picture that you have shown us. Introduce our first speaker of this evening. It will be Dr. Gianluca Campo. Professor Campo is from University of Ferrara, Italy. He's a well-known interventional cardiologist and involved very heavily in international trials. And his publication in the New England Journal on the FIRE trial is the topic of his talk this evening. I think that the trial is very important in consideration of the senile patients with the acute myocardial infarction setting. How do you define the lesions that need to be treated with the physiology? I think these are all very relevant and important issues. So please, Professor Campo.
Thank you. Thank you. Thank you so much for this kind invitation and to give me the possibility to share the data from the FIGHT trial. And in particular, I have some new news and data and sub-analysis from the FIGHT trial, so I'm very proud to have the possibility to share with you. So first, before to talk about science, please give me just a few seconds to introduce myself. I come from Italy, Ferrara. Ferrara is a small, typical medieval town from northeast of Italy. As you can see in the slide, we have some typical Massé attractions, so our castle, our major church. And regarding my hospital, is the University Hospital of Ferrara. The organization in Italy is different as compared to your country. In Italy, we have a public service, and any area is organized with a hub center with 2-3 spoke center for the referral of the patient. So my hub center covers an area of 350,000 inhabitants. Our major expertise is coronary intervention. You can see the number. In particular, I did my career, my research in the setting of intracoronary physiology and imaging. But now, as SMT, we are moving from coronary to structural intervention, and we are very proud about the possibility to start this trial investigating the feasibility and safety of TAVI procedure in center without on-site cardiac surgery department. This is our website, and you can visit the website to have more information about our research group and our study. Now coming back to the presentation, to the FIGHT trial. The goal, the main objective of the FIGHT trial was to investigate if in older patients with MI and multivessel disease, complete revasc was superior as compared to culprit-only revascularization. But before to show the main findings of the trial, it's really important to understand the background behind the trial and behind the selection of supraflex screws as a stent inside the trial. In particular, the FIGHT trial, why is a unique trial? Because we collected information in a population without data before the FIGHT trial. You have a lot of data from randomized clinical trial assessing interventional strategies in male patient aged 60 years old. But you don't have any information, more complex patient, more complex situation. And in the FIGHT trial, we collected patients at a high risk of periprocedural MI, high risk of acute kidney injury, and mixing high ischemic risk and high bleeding risk. And this is very important for some data that I will show you. If we analyze some of the most important baseline characteristics of the FIGHT trial, you immediately can see the difference between the FIGHT trial and the previous trial. Our population was 20 years older, more diabetes, more female sex, worst clinical presentation with a lot of heart failure at hospital admission. And regarding coronary artery disease, this is the typical FIGHT patient. A lot of chronic total occlusion, severe calcification, long lesion, bifurcation. So a mix of population at high risk and the opportunity to give some important information on how we can improve the management of this patient. The other key point is why we selected for this study supraflex screws. And we decided to have this stent on board for some technical, clinical, and experience information that I will show you. So first, Cruz is a ultra-thin platform, 60 micron for all the diameters, with a biodegradable polymer, eluting sirolimus mainly in 4 weeks. And the peculiar characteristic is the presence of this LDZ link, very important to improve flexibility, pushability, and trackability. On top of this characteristic, because we were searching for a stent with great technical characteristic to treat complex patients, there were some important data in the head-to-head comparison with Xience, the gold standard stent. So at the moment of the protocol of the FIGHT trial, we had the data from the 3-year follow-up of the TALENT trial showing the non-inferiority of Cruz against Xience. But more important, we have some important data from other studies, from meta-analysis, showing how probably ultra-thin platform can be better when you treat a complex patient. And in particular, if your goal is to reduce target vessel failure. The last important point was our experience. We started to work with Superflex Cruz, and as you can see in the slide, the main feeling that we receive is the great deliverability of the stent. As you can see in the slide, how easy it is to achieve the target lesion in a LDA with severe tortuosity. So, mixing personal experience, scientific data, technical characteristic of the stent, we decided to perform the FIGHT trial with this platform. The design of the study was quite simple. We decided to work in older patients, 75 years old or more, admitted to hospital for MI, including both ST segment elevation MI or no ST segment elevation MI, patient with multivessel disease, a clear culprit lesion, and patients were randomized to culprit only or physio-guided complete revascular. Why we decided for physio-guided complete revascular? Because we need to select the lesion needing PCI to minimize complication and to maximize the potential benefit of revascularization of the non-culprit lesion. The results are real, clear, and evident. The next year, at the next ESC Congress, we will present the 3 years follow-up, so the analyses are ongoing. At 1 year, there was a significant reduction of complete revasc in terms of death, stroke, MI, and ischemia-driven revasc. But please note that also the secondary endpoint were positive, so a significant reduction in cardiovascular death, MI, ischemia-driven revasc, without any concern regarding safety. No stroke, no acute kidney injury, no bleeding complication. So the positive effect in this complex population by complete revascularization was very strong and clear. The paper has been published in the New England Journal of Medicine, so we are very proud about to share this publication and to achieve this important goal. But we are here not to talk about the main analysis, but to share with you some cases and some additional analysis in some particular condition. In particular, as you can see, the most challenging clinical presentation that we have in our daily practice. And I will start from HBR patient. And please, focus your attention in this important slide. Superflex Cruz is one of the stents with more data regarding HBR patient. We have 3 different studies, and I will show you the data of the individual patient data meta-analysis that we are writing regarding all the 3 studies. So we are talking about a stent with a lot of data in this specific subset. Why HBR patients are challenging? You see in the slide. HBR patient means very high ischemic risk. A patient classified as HBR show an incredible high risk of death and MI. But the problem is that you cannot rely on the APT to reduce the ischemic risk. So you cannot rely in clopidogrel, ticagrelor, prasugrel to reduce stent thrombosis or myocardial infarction or cardiac death. So you need something different. You need a good stent, a good implantation technique, and obviously you have to find the way to reduce this ischemic risk. I will show you a case. So it's a male patient, 81 years old, hypertension, prior smoker, dyslipidemia. The patient had a history of atrial fibrillation in a doxaban with moderate kidney dysfunction. The patient was admitted to our hospital for no ST segment elevation MI. As you can see, you have a long intermediate lesion on the RCA and a subocclusive thrombotic lesion on the proximal LAD. We can discuss a lot about the management of this patient. We can decide to put just a stent on LAD. We can proceed for complete revasc. We can use a staged procedure. We can assess non-culprit lesion with physiology or with angiography. Many options. What we did? We started with the treatment of the culprit lesion, so predilation, the implantation of one stent, supraflex screws 3.0 28, and the post-dilatation with non-compliant balloon with a great result, as shown in the slide. And after, what we did? In agreement with the protocol, we proceed with the functional assessment. In particular, in this specific case, we use a microcatheter-based FFR system, and you can see the pullback showing the functional positive drop related to the lesion in the mid-RCA. So we proceed with the revascularization, with the implantation of another supraflex screws, 3.0 32, and the post-dilatation with non-compliant balloon. But now there is the most challenging condition. So how to manage the antithrombotic therapy of this patient? This patient is a high ischemic risk, older, admitted for MI, multivessel disease, 2 stents implanted, and you may have some possible combination. You can use ticagrelor, clopidogrel, you can do dual antiplatelet therapy or dual antithrombotic therapy or triple antithrombotic therapy. I will try to motivate you to go down with antithrombotic drugs for this patient because our goal was to minimize ischemic events without increase the bleeding risk, without giving bleeding complication, because bleeding complications are strongly associated to mortality. In the FIGHT trial, the large majority of the patients show HBR characteristic. 70% of the population show HBR, met HBR definition, and in particular, 50% of the patient met the definition 2 times or more. So a very high bleeding risk population for age, for concomitant anemia, for concomitant use of oral anticoagulation, for moderate chronic kidney disease. Despite, as you can see, a very short DAPT regimen, the complete arm with more stent won the comparison with culprit only. So also in HBR patient, we achieve a great reduction in ischemic events with complete revasc. So it's not a problem related to DAPT, but it's the key point is stent implantation, good selection of the lesion, and good PCI technique. Similar data come from Cruz HBR study. As you can see, the Cruz HBR study was a single arm prospective study enrolling more than 1,000 patients performing PCI with supraflex screws, and more than 450 patients were at HBR. As you can see, the rate of adverse events as compared to leaders-free trial, so a polymer-free stent, were lower. Same data come from the Compare 6080. Compare 6080 is a head-to-head comparison between Cruz and Ultimaster. So ultra thin against thin stents. And with very short DPT regimen, we achieve the same goal in terms of ischemic and bleeding events. But if this is not enough for you, we have also all the data put together in a meta-analysis. What we did? We started from FIRE, Cruz HBR, and Compare 6080. We selected patient matching HBR criteria, and we selected patient treated only with supraflex Cruz, so no prior PCI, no prior different stent, only supraflex Cruz. We divided the population in patient receiving very short DAPT regimen, less than 30 days, and the patient receiving a longer DAPT regimen. And as you can see, the management of dual antiplatelet therapy was very aggressive. So no patient in DAPT after 30 days. And the results are incredible. No difference in ischemic events. So DAPT, if you implant supraflex Cruz, if you have a good PCI technique, does not matter. On the contrary, without DAPT, you can significantly reduce bleeding complication. And how is it possible? And please keep your attention in this slide. This is possible because supraflex Cruz, I believe, for a mix between technical characteristics related to strut thickness, biodegradable polymer, and elution of sirolimus, is one of the safest stent, also in the worst condition. If you analyze all the paper with all the other stent, no stent is able to guarantee a lower rate of stent thrombosis as supraflex Cruz. In the FIGHT trial, we had all the determinant of stent thrombosis: age, MI, severe calcification, bifurcation. Despite this, the rate of stent thrombosis, and despite short DAPT regimen, was lower than 1%. And in our meta-analysis, so 3 different studies, if you compare the rate of stent thrombosis, is not related to DAPT length. So this is a strong marker of the safety and efficacy of the device. Another key point population is diabetic patient. Diabetic patient, we will know, has show accelerated atherosclerosis, diffuse disease, long lesion, tri-vessel disease, so is a very high ischemic risk patient. In the FIGHT trial, complete revascularization was very effective in diabetic patient. As you can see, diabetic patients show a higher rate of adverse events, but in particular the difference is for culprit-only patient, because the reduction that we achieve with complete revasc in diabetic patient is very strong and larger. So complete revasc was effective in minimizing ischemic recurrence, and the performance of the stent was great. The ongoing Tuxedo trial will give us strong information. And please, be careful with this trial, because this trial will be very important for some important reason. The trial is enrolled patient in India, but the supervision of the study is based in US for an important point. So if you analyze the CSC committee, the DSMB committee, the executive committee of the study is based in US. Why this? Because it's true, Tuxedo trial is a comparison Cruz against science. But the key point of this landmark trial is the comparison with the cabbage arm from the Freedom trial. The Freedom trial has been conducted in the US. The database is in the US. What they want to do? They want to have data from modern PCI, so patient treated with last generation DS, IVUS guidance, so a good PCI technique, and to compare this population with the cabbage arm, trying to demonstrate if PCI also in diabetic patient is non-inferior or superior as compared to surgical revascularization. Another setting needing more attention because we are talking about cheap procedure. Cheap procedure are not only CTO or severe calcification. Cheap procedure are the most challenging clinical condition, and we will know how complex can be managed STEMI patient in the acute phase. This is a case, male, 76 years old, all the risk factor, including diabetes, no prior history, inferior ST segment elevation MI admission. And as you can see in the slide, we have the occlusion of the posterolateral branch, distal disease in the descending posterior, intermediate disease in the circ, and a very long and complex disease with severe calcification in the LAD, with at least 2 major lesions. Again, we can discuss a lot about this patient. We can discuss to treat only the right coronary artery, to treat LDA, to treat all the 3 vessels. Is a patient admitted for STEMI, diabetic, so the high ischemic risk is very, very high. What we did, we started with the culprit, this is obvious, so we decided to implant a stent in the posterolateral branch, post-dilatation, and after we treat the descending posterior just with drug-coated balloon because the lesion was very distal and the vessel very small. And you can see the good final result. As our practice, we proceed with functional assessment of the non-culprit lesion, and here you can see the pullback with the wire-based technology. In this specific case, as you can see, there was a negative value on the circ, a focal drop but a negative value, and a strongly positive value on LAD with 2 different drops. So to achieve a great result, you need to treat both lesions. And the same information comes from OCT. We perform OCT on LAD because the disease was very long. We have some doubts about the diameters of the stent. So we decided to perform OCT to have a great procedural plan in terms of length of the stent and diameter. And as you can see, we followed the plan. We implanted 3 different stents, post-dilatation with non-compliant balloon, and the final result was great, as you can see in the slide, with a good, well-apposed and expanded stent as shown by OCT. Being focused on the role of supraflex screws in STEMI patient, we can have some additional information from this analysis. This analysis, I presented the data at the recent ESC Congress, published on Circulation. This analysis was to support and to confirm the data from the FIGHT trial. So what we did again an individual patient meta-analysis, taking all the data from all the study comparing culprit only versus complete revasc. As you can see, we collected information from more than 1,700 patients, and the clinical follow-up confirmed the findings of the FIGHT trial, so a great benefit in terms of adverse events at a longer follow-up. But the key point for the stent is different. Please keep your attention on this slide. What we did, we started with 1,700 patients with STEMI treated with different stent platform. We divided patient treated with CRUZ from patient treated with durable polymer DS, and we performed a matched comparison CRUZ against Science and Onyx. And at 1 year follow-up, the results are supporting the superiority in the reduction of ischemic events of Cruz. And the next step is to increase the sample size. So we are performing a trial, the AIR trial, comparing complete revasc guided by angiography versus complete revasc guided by physiology. And this trial will collect information of a STEMI patient, more than 1,800 patients treated with supraflex Cruz. And this patient will be matched with the historical cohort from the examination trial. Examination trial is a trial performed in Italy and Spain under the supervision of Professor Sabaté. And our idea is to match the population, trying to understand if Cruz can guarantee a better performance as compared to science. Another case, patient with the left main. Now we move from MI to stable angina. So is a patient 75 years old with hypertension and dyslipidemia, admitted to our hospital for effort angina despite optimal medical therapy. The patient underwent coronary CT, and as you can see, coronary CT with FFR assessment with our flow system show two lesions, one in the left main and the other in the proximal LAD with a positive FFR value. Coronary artery angiography confirms the finding. So we have a first lesion in the predivisional left main and a second lesion in the proximal LAD. Again, what we did, we decided to go for PCI because the Sinta score was very low. And this is a small video showing the pullback of the wire. So we started inducing hyperemia. As you can see, the value of FFR is very low, is 62, 63. And during the hyperemia, we performed the pullback of the wire. And as you can see, you have at the beginning diffuse disease. When we are near to the first lesion in the proximal LAD, we have the first focal drop, as you can see now in the video. And after, when we are near to the left main, the second focal drop. So this is a clear demonstration that both lesions are significant, both lesions needed the treatment with PCI. This is what we did. We started with the predilation, with a semi-compliant balloon. After we implanted the first supraflex Cruz, a second supraflex Cruz, and really important in all cases when we manage left main, we conclude the procedure with the proximal optimization technique. This is very important, not only because we are talking about ultra-thin platform, but is really important because we are talking about left main. We have this important sub-analysis from the October trial. The October trial is a trial published on the New England showing the superiority of OCT guidance as compared to angiographic guidance in complex procedure. And one of the major subset of events was the left main. But why this? Because in an important number of cases, you leave some strat deformation, in particular in the ostium of the left main. The reason can be different: abluminal rewiring, fractured wire, guiding catheter collision is the most frequent cause. So you cannot see with angiography this. So you need imaging, you need IVUS, you need OCT, or otherwise the key point is to perform at the end of the procedure a final proximal optimization technique. This is very important because it's the only way to minimize the risk to leave some strat deformation, and strat deformation in the left main are associated at a higher risk of ischemic event. This is true for all the stent, not for ultra-thin platform, because the October trial was performed with science. And this is the final result of the procedure. So a very good result with an optimal functional pattern at the end of the procedure. Why supraflex screws can be very interesting for the treatment of left main? Because you have a large cell area, because you have an overexpansion capacity, and it's really important you have the diameter 4.5 that is able to achieve 5.5 millimeters. And in particular, again, this stent is very helpful for left main management, in particular because it's a great stent for the pot technique. And I show you why pot technique is really important for this patient. The key point is that the structure of the stent, and in particular the presence of LDZ links, allow the easy step down from left main to LAD. So you are able to achieve a good apposition both in the left main and the LAD without any trauma in the vessel. So this is a good stent, in particular because in your mind, when you treat the left main, you have to conclude the procedure with pot. This stent is well generated for pot technique. We have some data. We don't have a specific study investigating supraflex screws in the left main, but we have some information from the other trial. This is an analysis showing how 161 patients with left main enrolled in the 3 trials that we discussed before for HBR patient, and see the cumulative occurrence of device-oriented cardiac events in the left main versus non-left main is similar. And this is important because normally left main disease is associated with a higher risk of complication and adverse events. If you use a good technique, a good stent, you can significantly reduce the burden of left main disease and improve the follow-up of the patient. So, in conclusion, this is my last slide. What we understood in the last year is that the supraflex screws platform show a very remarkable safety and efficacy, also in the worst patient and coronary anatomy. So this is a great solution for all comers PCI, because if works well in complex patient, we will have the same result also in more complex condition. And in particular, we have a lot of data for HBR patient. And you, with supraflex screws, you can use very short DPT regimen without any impact in the ischemic events and reducing bleeding complications. So thank you so much for the attention.
Thank you. Thank you, Professor Campbell, for a nice presentation, really. So it gives us very detailed information regarding the trial and also the interpretation of the trial results, not just for the FIRE, but also across the board, the other trials involving the supraflex screws. According to the schedule, we are going to have a discussion at the end. So maybe you can take time to have your dinner first. So let me introduce our second speaker for this evening. It will be Dr. 刘俊廷，刘准，我们用中文吧。刘俊廷主任是新竹中国的心脏科主任。那同时刘主任呢，也是在我们介入界非常的活跃的一位医师哈。他在介入的这个技术啊，还有另外的话，就是在学术的研究啊，各方面都有很多的表现。那我们也认识了很多年，每一次听刘主任跟我们讲 case 呢，都很精彩。那么今天刘主任会跟我们就台湾的Superflex Cruise 使用的一些经验呢，做 case 的分享。据我所知，他应该也是在台湾使用这种支架经验最多的医师之一啦。好，那这样俊廷请，谢谢。
谢谢高主任，高主任介绍。那现在回到中文的场子哈，那不过还是有，我看一下 slide 还没出来哈，播放一下。OK。 我们可以 share 一下 slide 吗？那就是目前有些经验在用一些 ultra thin 的DES， 尤其是 superflex stent。那最近1年大概有些经验呢，要跟大家分享。那因为我原本以为是英文演讲，所以还是很怕讲错，就讲了一个 opening 哈。就是我发现就是目前场子里面有很多大家专家来莅临哈，尤其是那个我们的Professor Campo， 还有那个 Professor Cao 哈，就是我们的 Chairman of Taiwan Society of Interventional Cardiology。那他们大家都很对这有经验啊，我怕在这边讲是班门弄斧啊。不过我有些经验还是想跟大家分享。那我们知道Cruise 在 safety 和 efficacy 上面，刚才 Campo 已经跟我们讲说很有效果，然后在尤其是 high HBR 的病人非常有帮助。那它 durability 还有在 complex case 的运用上面有没有什么特别的困难，或是有些想法呢？我跟大家做一些分享。那我 slide 比较多哈，如果大家觉得时间太长哈，随时打断我没有关系。那我们现在第一个 case， 我第一个 case 是一个76岁女性哈，高血压胆固醇没有治疗，非常紧张，那 angina 一直持续，所以没办法用药治疗没有效果。那她的心电图看起来是正常的，那X 光片看起来 tortuous of aorta。那她在别的医院做了一些 coronary intervention CT 哈，大概发现大概在mid LD 可能怕会100%的堵塞或是一个 critical lesion。那 circ 90% 狭窄，那 RCA 大概有60%-70% 狭窄。那因为 unstable angina 拿来做了导管哈，这个 case 我们看它在去年7月，这是我第一个放的 case， 到现在大概1年多的时间。这边是 snapbox approach 啊，那 aorta 比较 tortuosity， 不过还是 approach 到了。那我们看它最主要 critical lesion 是 LAD， 还有大概在 OM 的地方有 critical lesion， 那很成功的放了2个支架。那 IVUS 在 left main 看起来大概有50% 的狭窄，不是很严重哈，所以大概就这个是在前一次的 index procedure。那后来接下来这个是 result 第一次 result， 那它的 RCA 呢看起来大概就是60%-70% 狭窄，因为不是非常的critically stenosis， 那 procedure 2 vessel 已经做完了，所以这个时候并没有做治疗。不过经过5个月之后呢，病人还是一个 angina 来住院呢。那我们看看它也是一样用 snapbox approach， 那 left coronary artery 看起来都不错，那都没有特别问题啊。那 RCA 看起来似乎有一点点 disease progression。等一下我 slide 有点荡掉。那 RCA 看起来是 disease progression 哈，所以大概就是在70% 狭窄，所以 snapbox approach 之后呢，我们在 completion 呢做了 balloon dilatation。那这是第一次使用，看起来是有一些 dissection， 还有一些 residual stenosis。那第一次不是很确定它的 superflex cruise 的 deliverability， 所以大概用 4.0 的cruise stent。不过很顺利的、很意外的推送反正蛮简单的哈，很容易就推到我们 target lesion。不过因为第一次选的 stent 不够长啊，所以原本想在中间的地方 cover 2个 lesion， 不过大概没办法 cover， 所以就把 lesion stent 呢再放到远端来，放了第一支 stent。那 stent 放完之后还蛮顺利的，然后就放了第2支 stent。那第2支 stent 大家看起来我们在overlap 的地方看起来其实还蛮 smooth 的approach 到很快的 overlap， 并没有明显的 stuck stent 并没有明显的 stuck 或是被挡住的感觉，所以效果是非常好的。那最后就是放了2个 stent 啊，所以7月份开始，去年开始放这个stent 之后呢，看起来12月份开始放 stent 之后到现在，我觉得对这个cruise 会有信心的。事实上不到1年的时间，所以做了比较多的 complex case。那这个是第一个 case， 看放了2支 4.0 的大的 cruise stent。那接下来就比较一个 complex case 啊。那我们第2个 case 是一个tortuous 的CTO circ CTO 还有 lemon bifurcation lesion。那病人男性66岁，高血压高血脂，然后平常有跑步，但是因为最近症状改善变严重，所以后来做了把 TET positive。那他的TET 看起来是 ST depression 啊。那30 EKG 看起来没什么特别的发现。我们看一下这个 lesion 是在left main 的 distal 地方蛮明显的狭窄。那 circ 开口似乎有狭窄，最主要是在circumflex mid portion 地方有一个 CTO lesion。那个 lesion 看起来又像有个 functional CTO， 又像是一个bridging corridor CTO。那这个 steel 的 frame。可以看一下别的角度啊 ，LD 也是个 diffuse disease 啊，那 LD 非常重要，它一直一直在延伸到这个 LD 的 apex 的地方。这是 circ 的 lesion 啊， 一开始认为 circuit lesion 可能是很好的过的 lesion 啊，所以大概用双输入，不过看起来是 fail 到 pass， 因为它血管比较狭窄，之外呢，而且特别弯曲。我们看到它这个 lateral view 的地方，看起来是非常的弯曲啊。那一开始的时候就是用 coarse microcastular tip injection， 那看看有没有什么micro channel， 似乎有一些 micro channel， 所以想说用一些比较 taper 的wire， 一开始用 Philips XDR wire， 可是看起来还是没办法达到它的远端哈，转角非常的强，尤其在看它 lateral view 的地方，看起来事实上是不是很好的过的这个 lesion， 或许是这个 CTO 有一个 bridging collateral。那最后在做 tip injection again 之后，然后用了 Gaia first 到 force lumen， 2次都到 force lumen， 在一个转角的地方是非常难到 approach 的。最后Gaia first 还是到达 force lumen， 没有办法达到它的 entry point。不过 Gaia first 最后还是看起来这个角度，我们看 AP view 看起来还是可以的，但是 lateral view 看起来还是到 force lumen。最后看起来我在 Gaia first 做一个 second curve， 做一个 bending， 最后转到一个直角之后进到一个 true lumen。最后很顺利的进到它的 distal 的 true lumen。那这个 lesion 之后呢，后来我们就是用Gaia 越来越更前进之后呢，我们就达到recanalization， 那到 distal true lumen， 那换了一个 workhorse wire， 然后再做一个 stent， 那这个过程就是很比较顺畅了，这个就只要 deteriorate， 然后最后做了一个 IVUS， 看起来是在 left circumflex ostium 是 disease free 的，并没有严重的狭窄，所以大概决定如果是lemon disease 的话，可能 simple crossover 从 lemon 到 LD。那我们看一下，这个是 superflex deliver 到3.048 deliver 到 circumflex 的过程哈。wire 很难过去，但是它在过程很弯曲的 circumflex 很顺利的达到它的 target， 所以 superflex 当时越来越有信心，它在deliverability 还有那个在 torture lesion 特别容易达到。最后就这个 stenting 放置成功，那其实大概就是 circ 就成功了。那在 LD 的地方呢，就是放2个 stent， 这个是把弄用 cruise 的 stent 把弄来做 dilatation。最后这边选择 stent， 当时是因为 lemon 有到 5.0 啊，所以其实那时候在我们的导管是没有 available 4.5 的这个 cruise stent， 所以当时就选择其他牌的 stent 啊，当然做 spot stenting， 在LD 的 mid portion 和 lemon 地方做2个 spot stenting， 达到 5.0， 这是最后 final result。所以 circ 在这个 lesion CTO lesion 呢 treat for cruise 是一直在 torture state 很厉害的地方，达到很好的效果。那接下来看到第3个这个案例是我们新竹的病人哈，他是一个58岁足科工程师哈。那事实上他常常说他麦干压力很大，所以就抽烟，本身也有3高的疾病病史。那高血脂是很难控制的，吃了 Vital 加 Phenylfibre 还是一样 ，LD 有130。因为有运动胸闷的症状，所以就做了在北荣做了一个 coronary CT。我们看一下 CT 啊，这是非常 heavy 的 cascade， 那 VTR 的狭窄。那它的VTR 看起来，我们看一下这个角度啊，大概是 LD 和 circ 的 anatomy 是正常的 ，RCA 在近端有很大的 lesion。我们旋转之后看到 RCA 到2转3的地方，似乎的 contrast 的量是非常少的，有可能是 CTO lesion。再看到 distal 的 PL 远端呢，是从 circumflex 有一些 bridging collateral 进到 distal 的 RCA， 所以事实上可能 RCA 是真的是一个 CTO 啊。但是 RCA 当时的这个 CT 的 lesion 看起来 distal 地方看起来是 contrast 没有 feeling， 那 LD 的 lesion 是这样子。那这是这个 case 的今年1月份的照的片子，好，大家可以看一下，这个是 RCA 是在CTO 是非常明显的，而且在distal cap 的地方看起来是也是个 stumbled CTO， 是在 cross 在 PDA 和 PL 的地方。那从 LD 到 PDA 是没有什么的 collateral flow， 都是从很大的一个 circumference 的一个 bridging epicardial coronary channel 过来的。那大家一定很好奇 RCA 怎么样 ？RCA 看起来其实也是非常严重的狭窄，在一个 distal 的 branch 的地方就是一个 stumbled CTO， 前段的也是 heavy cascade， 不是那么的好做。那这个 case， 所以大概就当时就决定是 bilateral approach 啊，这就跳过去。那这两边是用 snapbox approach， 然后右边是一个7 French guiding SA， 放了一个 SA1 在右边 RCA， 左边是用6 French guiding， 那是用 EBU 3.5。我们 dual injection 发现两边的 CTO 是蛮长的，大概2公分以上，而且在2转3的地方，两边都是 stumbled。那它的没有 septal channel， 只有一个蛮大的 epicardial channel 从 circumflex 过来的。那我是用两边的 microcaster 做两边的 tip injection 呢，这样会减少一些contrast。不过打的过程是比较累一点点。不过在看起来的确是没有一个 connection。那选择的角度就是用在2:3是用 AP Coda 和 LL Cranial View 来选择它的角度拍的角度，所以大概它的 still frame 是这样子的情况，是蛮长的一个 CTO。那转角到底怎么转，其实很难确定。那 CT 给我们image， 但是还是没办法确定的。那最后希望是用 anti-gray approach 就能够成功哈。不过大概用转角度用 XTR 看起来都是会到 side branch， 用了 Gaia first 当做一个第一个 attempt， 在2:3的地方看起来钙化不严重，所以想说这边可以下去。不过往前是有 promising 的，不过看起来到 distal 到 false lumen 去，做了几个角度还是到 false lumen。最后看起来就是没办法的前进，可能是前面的 wire 太厉害了，所以在前面的地方做一些lesion 的 preparation 呢。那最后就是用那个 parallel wire technique， 可能像会进到integral approach， 不过还是没办法成功了，最后可能考虑 retrograde approach。这个病人可能是比较困难一点，不知道大家经验，这种在J channel score 里面非常高的一个 lesion 呢，到底有没有办法成功？我们再看一下它的角度哈，它大概从Epicardial channel 从 left second flare 过来之后，它是非常的 tortuous， 而且它是非常的corkscrew 啊，还有 reverse span、continuous span 和 looping， 这是非常的厉害。我们再看这角度，第一次 wire 我是用苏02啊，可是到了另外一个 side branch 去，那转角非常大。那我带的是一个Caravelle 的 microcaster。这个转角是 reverse span 非常困难哈，不过大概经过几次的这个 torque 之后呢，慢慢有 advance 到远端了，比较不可能容易一下子会 jump， 那我们 microcaster 跟会 jump 到远端去。那最后呢，会在这个地方看到一个 wire looping， 在这个地方要打一个转8字节哈，不过看起来另外角度看起来是很严重，看起来都非常困难的一个 lesion 啊，这个地方打了8字节，不过后来是一个 reverse span 之后，很顺利的 jump 到distal 的 PL 区哦，不过顺利完成了 cannulation， retrograde 的一个 microcaster 的 approach。最后在这远端呢，我们做一个 wire 是直接到 distal retrograde wire 是直接到 PDA， 没办法再往前走。那 tip injection 看起来的确是一个 stumbless 的一个distal cap。那最后两边 approach 之后呢，是用UB3 然后当第一个 wire。那没办法改成 Gaia first， 那最后 tip injection 还是有一些 channel， 但是可能到 false lumen， 没办法达到目标，所以两边没办法 kiss 在一起，最后可能用 Gaia next to。那 Gaia next to 事实上可以前进到接近 proximal cap 的地方，但是没办法再前进，而且甚至会闹出去血管里面。那最后主要调整角度之后 ，Gaia next to 和前 anti-grade 的Gaia first 有kiss 在一起。那最后做一个 kiss 之后，还是在 false lumen。那最后希望做一个 reverse cart， 不过看起来这个 distal 我们在 proximal cap 的时候那个地方很厉害的 lesion 啊，所以我用那个 1.26 的把弄还是没办法过去。那所以在近端的地方做 reverse cart， 那我们把 retrograde Y 能够迎接过来。事实上 retrograde 大概 next to 事实上有到前进了，不过没办法转到 segment 1 2的地方，没办法转进去。所以在做了一个Gaia next to 也是没办法进到 proximal RCA。那近端再用大的把弄打出来之后呢，甚至有个 extension caster 再往前接，还是没办法接成功。最后看起来没办法成功之后，整个 wire 这个 prolapse， 什么概念 prolapse 下来之后的 wire 都跑出来。不过仔细看呢，大概是在 tip 的地方就接近retrograde 的 microcaster 接近它的 proximal cap， 所以想说我们试看看，打个药看看有没有接近呢？那我仔细看起来，事实上我们retrograde microcaster tip injection 之后的它的 flow 可以到了 AM branch， 所以事实上有个小的 channel， 所以想说有没有可能从 anti-grade 再下去啊？所以这个时候我再把那个 retrograde 的 microcaster 放在原处 ，anti-grade wire 就是用 tip in 的方法就进到前面的retrograde 的 microcaster， 所以后来完成了它的anti-grade 那个 wiring， 那 wiring 就 deep seated 到深插到distal 的PL。但是很不幸的就是我这个 lesion 还是 uncrossable 哈，用了 1.26 的 mini track， 用了 extension caster， 用了 1.0 的把弄做 tornado， 然后用 turnpike gold 也没办法。那最后用一个 Cosel Pro 想要旋转进去，但是 Cosel Pro 最后很不幸的跟 wire 咬在一起，那不得不把所有的 device 都拿出来。那最后这个病人大概就没办法成功啊，那个 anti-grade flow 就看起来 没办法达到reestablish。那但是 retrograde 的看起来的 tip injection 看起来这 flow 也同样可以到达 AM 哦，所以事实上两个 channel 是有相通的。所以这个病人后来最后没办法完成，这是最后 LD 放了 stent 的 result。那这病人4个礼拜之后呢，其实赶快就叫回来了，这个就比较简单一点点。那这是第一次的 RC 的第一巡4周前，那4周之后大家可以看到有 antegrade flow， 可能是上次 retrograde 的 channel 被打开来之后 ，antegrade flow 有到远端去，这个就比较简单，觉得很 easy 哈，所以大概就在这个地方放了 wire 进来，但是事实上把动还是没办法过这个 lesion， 所以就是没办法 microcast 过不去，只好用 rota wire 的 bare wiring， 然后做了 rota 的 rotation 啊 atherectomy。不过很不幸的，这个 rota 还是没办法过去 1.25 还是没办法过去，而且是最后在我的这个 rota bird stuck， 然后它的 drive shaft 整个 fracture 没办法下去，所以只好把整个的 device 和 wire 一起拿出来。好，所以这个 lesion 是 CTO lesion， 虽然 wire 成功2次，但是都没办法达到它的lesion 没办法 cross。这个拔出来之后呢，我们再照看起来是非常厉害的 dissection 啊，这个想说这个 lesion 是非常困难，不过这个病人没有症状，所以我大概就仔细的在 wiring 很幸运的这 distal wire 到远端去。这个时候 wire 完之后呢 flow 还是没有，不过把弄就可以下去了。所以大概这个病人做 lesion modification 之后，虽然bird 没办法下去，那但是 wire 还是能够成功，最后的把弄能够下去。那最后我们做把弄之后呢，最后做了一个 preparation， 然后最后是 advance 它的 cruise stent。在这个 lesion prepare 完之后，大家可以看一下这个 lesion 刚开始的时候那个stent 左边的屏幕没办法完全下去啊，事实上还是有时候它的 deliverability 还是有受到限制，因为钙化太严重了，所以最后还是要一个extension caster 把 T 讯送到远端，所以在远端的地方放了一个 stent， 中间放个 stent，proximal 放个 stent， 这是最后3个 cruise 的一个 stent 的结果，看起来 final result 是还不错的。那 side branch 是有点还是 preserved 的，所以在一个 CTO lesion 呢，虽然做的很厉害的很严重的钙化，但是我看 SuperFlex Cruise 还是可以达到它的 revascularization 的效果。那最后带个几个比较简单的 case， 比较快的 case 跟大家讲。这是在钙化和 torture 的地方 deliverability 比较困难的地方你看一下这个比较稍微简单的 case， 不过它就是一个 tortuosity， 那 LD 是一个非常的 curving 的一个角度，然后 circle 也是一样。那这个RC 的地方也是一个非常的tortuous， 所以这个病人是属于 pure vessel tortuous vessel。那 RCA 在放 cruise stent 之后，大概 deliverability 也是不错的。那 LD 的地方看起来是钙化非常严重。那一开始的时候希望能够使 cruise 能够下去。我们在推 cruise 的时候可以看到远端比较短的 stent 呢，马上就下去了，并没有受到阻碍。2.5、2.0、2.520的 cruise， 不在近Iris 可是却下不去哈。那不过下不去之后，这个是在近端的地方 cruise 的开始 deliver 是有点困难的。不过在 push 之后呢，可以看一下右边的荧幕之后，慢慢有下去，就是开始 push 是要困难。guiding 在 coaxial 之后就可以下去，所以这个转角90度的血管lesion还钙化lesion还是可以下得去。那最后在这个地方做一个stent deploy， 最后这 LD 的结果看起来是还相当理想。那 laminate disease 呢，看起来是有点严重，但这个角度看起来不会特别厉害。那这个circle也做了一个 cruise stent， 最后完成。所以在钙化狭窄的角度呢，都可以达到成功。那还有一些少部分经验是在用 cruise 来做一个 tap stenting。那这个 case 是相对简单的，可以看一下 LD 的 lesion 是在近端的 lesion， 然后还有中间的 lesion， 看起来是 intermediate lesion 的，不过 Iris check 之后的确是有明显的狭窄。那 RCA 是一个 high tackle， 不过是血管是 patent。那在 LD 呢，我们会做了 Iris 评估之后，狭窄的程度事实上是非常严重，有 70% 以上的狭窄，所以在近端放了一个 stent， 放了很长的一个 cruise 48的进到它的 lesion。做完之后呢，事实上它 side branch 是有 occlusion 的，所以我们大概做了 rewiring， 然后可以看到 rewiring 之后呢，事实上 2.5 NC 把弄直接就下去了，并没有需要用 1.5 的把弄做 predilatation， 而且是 NC 把弄直接做过了 side branch， 经过 stent strut 到 side branch 去，所以是蛮容易。它可能是 stent 的 opening sail 是蛮大的，那 side branch open 是可以很大的达到它的那个hole， 那 sail 是很大。最后做了 kissing， 那 kissing 完之后想说做一个 pot。但是它的DB1 的 ostim 是有 dissection 所以大概还是要做一个 bifurcation 的 stenting。那这个时候在 Iris 在diagonal 还有 LD 做的评估啊，还是蛮明显的狭窄。那在做第二个 stand 的 cruise stand 大家可以看到非常 easy， 还是从那个 side branch 的开口就直接经过 stand 到远端，然后做一个定位，做一个 tap standing 的定位。那最后再做一个 kissing 之后，简单再做 pot。那这是 LD 和 diagonal 做 kissing 完的结果，效果是相当不错。这个是一个 tap 的 standing 的经验。这是 final 的 angel。那最后一个 case， 这个 case 是 LD 和 circumflex lesion 的。刚才我们提到就是那个 cruise 的 expansion limit 是比较大一点点，大家可以看到 LD 在近端是有个 aneurysm formation， 但是接下来就 lesion 一个 lesion 啊，所以这个在选择 stand 的时候是比较困难的哈。不过因为 cruise stand 的 extension limit 是比较大一点点，所以当时我就在LD 的地方放一个 superflex cruise 的 3.5/40 的一个 stem， 然后近端做一个4.5 把弄的 dilatation， 看起来 result 是不错。那这边要 share 就是在 circumflex 的地方呢，事实上这个是术式，是一个是 mini crush 的术式。最后的结果看起来是很理想的，好，那右边的血管看起来是还好，所以大家最后 final 结果看起来是在这个地方做了一个mini crush， 所以第一个是 tap， 这个是 mini crush， 效果都很不错。好，所以 superflex cruise stand 呢，在我的 daily practice 里面呢，它是一个不然是我 simple 或是 complex lesion 都是很好用的stand。第一个它是有 ultra thin 的 design 哈，所以在 stand thrombosis 的机会，就 HBR 的病人可以做short depth 的治疗。另外它是设计上比较 long stand， 所以它在使用上面呢，可以 cover 多的 lesion， 同时做一个比较好的一个治疗，可以节省病人的一个花费，而且是达到治疗效果。那可以选择它的size， 可以比较选择稍微 for distal 的 lesion， 那尽量可以打大。那 deliverability 呢，事实上是非常的方便，非常有效。那最后是 safety 和efficacy， 大概前的讲者已经介绍过，就不让大家赘述了。那这是今天简短的 case sharing 啊，谢谢。
各种的这个治疗的技巧大概都看到了哈 ，CTO 的分叉病变的 left main 的钙化的 rota， 非常的精彩。So I think we will now enter the segment of discussion. So please, can we ask Professor Campo and Dr. Liu to be on the stage? 我们现场do we have any comments or questions for the presentations? Both doctors and colleagues here, and also the online audience, can they also raise their questions? And how can we respond? Sam?
Yes,
yeah, sure, please.
Comment to the cases, wonderful cases, great technique, and I believe is the right direction to use current technology. I see a lot of use of imaging, a long stand to minimize untreated disease. So, sorry. I repeat, so congratulations for the cases, very well done cases. And I really appreciate in particular the use of imaging also to guide stent implantation, the selection of the alignment of the device. And in particular, as you can see, if you perform a very well done preparation of the lesion, also long stent, large diameter can go down to achieve the target and to cover all the disease, all the lesions. So I believe all the cases were a great example of how to use current technology. And again, if this patient have some particular characteristic, for example, are at high bleeding risk, if you do a good implantation, a good selection of the device, you can stop the APT after 30 days without any problem because the stent is safe, you will not have stent thrombosis, and also the result in terms of stent restenosis will be great because the rate of stent restenosis is very low. I don't show the slide, but we have some important data from all the trial with superflex cruise. Stent restenosis is around 2.5%. It's very, very lower as compared to other registry because, for example, in European registry, mean rate of in-stent restenosis is around 5%. So you can go very, very lower with this device.
Thanks, Professor Campo. I'm 100% agree with your suggestion and comment. In the beginning, the cruise it was introduced to our hospital because of its feature is that the durability and the length of the stent. So it has a benefit for our patient. But after your beautiful lecture, I realized that not only the technical consideration, but also the efficacy and the safety concern for that patient. Nowadays, I'm more confident for my patient, especially very complex lesion, left-man triple vessel disease, acute coronary syndrome. I'm very confident to using the cruise and to facilitate my stent delivery and save the patient's money because of the long stent, and I can treat all the lesion maybe in one procedure and without many difficulty. So nowadays I'm very confident about this kind of stent.
I think the consensus here is that you need a good device, but also you have to implant it correctly without the help, without the technique. Professor Campbell mentioned about the October trial, which is a very, very important one. Actually, if using angiogram, maybe up to 50% or more of these stent deformation can be missed. And if you miss that stent deformation and without doing anything to rectify it, actually it translates into clinical outcome. So it's not a benign thing. So we should use...
No, it's very important because I will know, also in my practice, I do not perform all the procedure with the guidance of imaging of physiology. But it's really important to have this information, to read the paper and to perform some cases because, for example, when you start to use intracoronary imaging, the first feedback is probably you downsizing all the stent before. So this is a great achievement for the patient because you start to implant more 3.0, 3.5, 4.0. And this is better for the patient. Again, you cannot use probably intracoronary imaging in all cases when you treat left main or when you treat bifurcation, but the feedback is remember to perform final pot as last action that you do. Because you are right. If you perform final pot, you are right. So this is very important.
I have a question to Professor Campo. Some doctors tell me that because the design of the cruise stent is ultra thin, 60 micron. So they think that the cruise may be more benefit in used in the small vessel and the diffuse long lesion, but not very needed for the large vessel. How you tell them?
This is a great comment. Also in Europe, the comment is quite similar, but it's not true. Because why ultra thin? Because I stressed in my presentation the safety of the platform. And this is related to ultra thin design. Because remember that probably the difference between 60 and 80 micron is minimal. But one of the mechanisms inducing stent thrombosis and disease is the high shear stress near to the strut. And 60 or 80 micron is a great difference. And this is true in small and large vessels because the shear stress around the strut is one of the mechanisms inducing stent thrombosis. So if you are able to minimize the stent strut and to do a great implantation, well opposed, well expand, you minimize the shear stress inducing stent thrombosis.
The second question is that the design of the cruise is the 2.5 to 3.5 using the same platform. Once you overspended the proximal part of the stent, maybe the scaffold, the covered area, or maybe tissue protrusion or drug delivery may be less. Do you have any opinion or suggestion about that?
Also, this mechanism, this is true. But remember that when we talk about the risk of future events and the stent restenosis, is not important the protrusion, but the different elution of the drug. So the great advantage of CRUZ is the ability to maintain the biodegradable polymer despite a great overexpansion and an uniform and constant elution of sirolimus. And this is the key point to have low stent restenosis and no future adverse events in the follow-up.
Excellent answer.
So regarding the durability of this polymer, is there a special formula for it? Because if we use CRUZ stent in more tortuous, more calcified, more difficult lesions, so inevitably, maybe you will be scraping the stent against the wall, right? So what is the durability of this polymer?
No, the durability is very great. In particular, we have a lot of data showing the ability to release in a very constant way the drug. This is the key point, because remember that in the first generation DS, the issue are related to polymer, because in some point polymer were very concentrated. The release of the drug was not constant over time in the different zone of the coronary segment. With this new technology, we don't have this problem. And this is why we see in all the trial low stent restenosis, low stent thrombosis. So it's probably is a chance during technological development, but the combination is great. Ultra thin plus biodegradable polymer, you are achieving a great result.
I think SMT just hit the sweet spot.
Yeah. I think, I mean, as you know, some of science is by design, but some of it is by serendipity. We'll never know which one is where, but I do know that it is a proprietary polymer. We have triple layer, and the drug is well encased in the middle layer, so that to the concern that you raise is not really an issue. So we're seeing quite spectacular results across complex population.
Do we have any comments from the floor? What about our online audience? No, okay.
I have another question for Suri. You have introduced the new product of CRUZ Naval. Yes. I think that the CRUZ is very good for the durability. Is there more advanced in the CRUZ Naval? Is there any know-how or another design for that?
Yeah. Have you had experience with Naval?
No.
Okay. So yeah, in terms of, you're absolutely right that I think from a deliverability perspective, and especially seeing your cases, even I'm blown away, such tortuous cases and difficult ones. But we see the delivery systems being improved even more. So in terms of push transmission, in terms of trackability, it's a lot better than even CRUZ. So.
I want to start to use
So, may I ask you, for example, if you are using a 6-French guide, can you have two Superflex screws at the same time? Can be delivered simultaneously, or?
No, I prefer don't do this with do stand in the 6-French, because you can use small diameters, but you have a strong risk to dislocate the stent. So it's better to avoid two stent in a 6-French guiding catheter.
Right. Okay.
Thank you.
So I think our speaker has have done a very wonderful job. Most of us are contented with the result of the trials, and also we are amazed by these very complex cases. So with that, I think we can close the session, and thank you very much.
Thank you.
Professor
Thank you
Campo
for inviting me.
Dr. Liu,
Thank you
for this wonderful presentation, and also SMT and Guangtai for your hospitality. Okay, thank you.
Thank you.
Thank you.
Thank you.